welcome back. In our previous lesson, we talked about a paper from 2008 that Gilles Levine had done as an overview for clinicians about the relationship of apnea and bruxism. What I want to do in this lesson is look at some more current research that basically informs us it's not always apnea or hypopneas and bruxism. There probably are some other relationships that might be triggering the bruxing event. So this is a patient that actually came to our office and saw my partner, Greg Kinzer. And the patient, late 40s, tremendous amount of tooth wear on his anterior teeth. He's very concerned about wanting to do something. And so the question becomes, where do you go with this patient? What do you do? And so in the previous lesson, I shared with you research that really showed that in some patients, if you manage the apnea or the hypopnea, the bruxism goes way down. But do we also have research that tells us that there might not be a link all the time between the apneas, hypopneas, and the bruxism? And the answer is yes, we do. So what are a few of those things that tell us that? Well, one thing is this. As people age, their incidence of bruxism, nocturnal bruxism, goes down. So if you look in children, 14 to 20% of kids 11 and younger brux at night. 13% brux between the age of 18 and 29. By the time you're 60, only 3% of adults brux by the time you're 60. So nocturnal bruxism is actually going down with age. Now, just so you know, daytime bruxism actually goes up with age. So daytime bruxism reaches a peak of around 20%, 1 in 5 adults, by the time you're 50 or 60 years of age. Now, let's talk about, so as we get older, our bruxism incidence decreases, but what happens to apnea? Well, in children, apnea is not as big an issue. Only 2 to 3% of young kids actually are apneic. The peak incidence of apnea in children is between the ages of 2 and 8, but upper airway resistance syndrome, that is, you still get an oxygen G saturation, you just don't qualify to be called apneic. Upper airway resistance syndrome is far more common in kids, so it doesn't really show up here because the 2 to 3% that's being talked about are people that are actually diagnosed with full-on apnea. Now, this is where you really start to wonder about, so what's happening with aging? If as you age, you start grinding less and less at night, what happens to apnea with aging? So let's compare the incidence of apnea in 25-year-olds to 60-year-olds. In females, by age 60, 32% of females are apneic. At age 25, only 4% of females are apneic. In males, age 25, 22% of males are apneic. By age 60, 42% are apneic. You'd look at that and go, well, if apnea was actually the cause of all bruxism, bruxism should be getting worse as we get older, not better. And yet, the research says it does get better. And so perhaps there's some other things involved besides classic apnea. And so if you go to this patient, what Greg did is had this patient wear for several nights a pulse oximeter. And on the top, what you're looking at is in fact oxygen saturation levels. And then on the bottom, you're looking at heart rate. In this report, you have an apnea-hypopnea index of 63. That's the combined number of apneic and hypopneic events in an hour. So in this report, what I want you to notice is whenever the oxygen level desaturates, you see a spike in heart rate. That's a really classic report that you would expect to see in some of the bruxes. Is every time you get these desaturations, boom, they're followed by this big increase in heart rate, and that leads to that cascade of events that leads to bruxism. That's the report you would expect to get on this patient, but that's not his report. This is his report. If you actually look at his oxygen desaturation, he never went before 94% the whole night. He stayed between 94 and 97%. And yet, if you look, when he had really minor levels of desaturation, his heart rate went crazy. And so what we know today is it appears that it might be very, very transient, low levels of desaturation that in fact are linked to the bruxism in these people that aren't apneic or hypopneic. It might not require the massive levels of desaturation you expect when you're apneic for 10 seconds or more. So your respirations decrease 90% for a 10-second period or more. Some people, that seems to be the etiology, but not everybody. And so this patient looks to be a good example of it's not a massive amount of desaturation that's causing him to grind his teeth. It appears to be a very, very small 1 to 2% desaturation that's causing him to actually go through the grinding behavior. So I mentioned in the previous lesson Gilles Levine and that paper linking apnea with bruxism. I want you to notice who the last author is on this paper. It's Gilles Levine. This is now 2016, 8 years after the paper from the previous lesson. Look at the title of the paper: A Weak Association Between Sleep Bruxism and Obstructive Sleep Apnea, a sleep laboratory study. What did they find? They took people who had both bruxism and obstructive sleep apnea, and they looked to see how common were the two events linked. Because in the 2008 paper, there was a really high correlation. And so the results say that half the time, sleep bruxism is not strongly associated in timeline with obstructive apnea. And so it appears, in fact, that apnea and hypopnea may be related to a higher occurrence of other types of sleep oromotor activity, but not necessarily always bruxism. That doesn't mean apnea and hypopnea isn't linked to bruxism. 50% of the time it was. But it means in 50% of those people, something else is going on. And what their paper said is basically there's something else happening. There's some kind of different mechanism. So now you go on again, and again, a Levine paper, could transient hypoxia, those little miney, they call them RERAs, respiratory effort-related arousals, where you get a minor 1 to 2% desaturation. Is it possible that that could trigger bruxism? And so again, you look at the timing. When was the bruxing event? What happened with the oxygen saturation? So they had 22 subjects. In 6 subjects, there was a slight increase in oxygen saturation after the bruxism event. In 10 subjects, there was a slight decrease, and we're talking 1%, 0.1 to 1%. Little tiny changes in oxygen saturation that are timelined linked to when the bruxism event. And then in 6 of the 22, there was actually a decrease of 2% in the oxygen saturation, or 1 to 2% following the bruxing event. So the findings suggest that there's some subgroup of bruxism that actually occurs after minor transient hypoxias. And what it's doing is it's giving us a different way to think about bruxism and managing these patients, because we've been so tuned in to thinking that it's apnea and it's hypopneas and that's what's causing the microarousals. And now we're realizing that that's one group of patients, but that's not everybody. And so in a patient like this, the question is, what do you do? And, how do we make sense of all of this? Because now, if it was just apnea and hypopnea, it would be easy. You send them for a sleep study, but sleep studies oftentimes don't report on the RERAs at all, the respiratory effort-related arousals. So I think we can kind of take this home in terms of making sense of what we know today. The etiology of bruxism isn't just one thing. It's clearly multifactorial. In some patients, bruxism is preceded by apnea, for sure. In other patients, it's preceded by a very mild, very tiny desaturation. And in still other patients, there doesn't seem to be any change in oxygen saturation prior to the bruxing event. For sure, in some people, it appears that stress plays a role, but not necessarily in everybody. And, if you have a patient where oxygen levels are involved, like apneic and hypopneic patients, we do have pretty good evidence that if you can correct the apnea or hypopnea, your bruxism goes away significantly. But what do you do in patients that don't have that, right? And so for me, this is how I kind of make sense of it. My history would have been to want to believe that, well, I'm going to find the answer that's going to cure their bruxism, and if I cure that, they're going to be fine. Today, when I see somebody who goes through and you assess their oxygen desaturation and you don't see anything significant, and yet you see evidence of significant attrition from bruxism, to me, the safest thing to do is to assume your patient's going to continue to brux. Don't assume that what you're going to do is going to stop the bruxing behavior. And what that means is I develop occlusions today to try and survive the bruxism as though it was going to continue. What that really means for me is distributing forces on multiple teeth, both in intercuspal position as well as when the mandible's moving. So what did Greg end up doing with this patient who had the significant wear? Well, he has an end-on occlusion. He'd had 4 premolars extracted when he was younger. If we look at his anterior tooth position, his maxillary anterior teeth are actually retruded, probably 3 to 4 millimeters from where you'd like to see them. So Greg needed to get overjet for this patient because he didn't want to treat him in an end-to-end occlusion. So they talked about possibilities, and they ended up talking about the possibility of actually orthognathic surgery to move the maxilla forward, potentially even move the mandible as well. And interestingly enough, that's what the patient did so that he could then have his teeth restored. Now, he doesn't need a full reconstruction. He really just needs his anteriors restored. What's fascinating is, and I don't have photos yet of him post-orthognathic, but the patient is aware, he and his wife, he doesn't brux. The bruxism appears to have almost completely gone away, even though he was only having these minor desaturations. What's interesting about that is that, in fact, if you look at orthognathic surgery in patients who have apnea and brux, it is incredibly effective at reducing apneas and bruxism. It's obviously not a light decision to make to end up going through double jaw surgery. But this patient wasn't apneic, but he did go through the surgery because, in fact, he needed the surgery to create overjet. And in this patient who had that very, very minor desaturations, his bruxism appears to have almost completely stopped. So my goal in this lesson was to try and fill in a little more information about the etiology of bruxism as to what we know today. Obviously, we're still learning, but it really does appear that we don't need to have large events, apneic events, in order to trigger the bruxism. Perhaps in that other 50% of the people, it's these very minor desaturations that are enough to do it. So I hope you've enjoyed the lesson, and I look forward to seeing you in the next one.